we repeat molecular profiling when the patients progress, especially patients that are that have fusions like ALK, ROS, and NTRK. The reason why we do that is because there is a very good documentation that these fusions suffer mutations. And these mutations are the ones that are creating resistance to the tyrosine kinase inhibitors. So in the specific case of ALK, we have a whole library of well-known resistant mutations that arise in these fusions when these patients are treated with tyrosine kinase inhibitors. So we learn from the ALK patients, we learn from the ROS1 patient history, and now we're learning the same from these patients treated with larotrectinib or entrectinib. By the time that we have all of this data published, we already have seen that several of these patients treated with larotrectinib or entrectinib have developed resistant mutations. For that reason, it's necessary to document the resistant mutations to try to find what is the next treatment. And this is probably more dramatic in the case of ALK, because in the case of ALK, we have already 5 FDA agents approved and 2 or 3 drugs under research. So if I have a patient with an ALK aberration that develops resistance, I have so many options for him. We really need to retest again. Now the question is, how do you retest these patients? It depends. If it's convenient to do a tissue biopsy, for example, the patient develops a new liver metastasis, single liver metastasis, and you are going to do some sort of local therapy, maybe it's convenient to take a biopsy and before to give radiation or something, local therapy like stereotactic radiation or radiofrequency ablation or something. If you don't have a lot of tumor, maybe the easy way is to do a liquid biopsy, is to do a DNA, sequencing DNA in blood, and try to identify the resistant mutation and get more information from these patients. That's why I think to repeat the genomic profiling of the patient is very important. Of course, is more focused, but however, we know that the patients are going also to develop other mechanisms of resistance, for example, MET inhibition or MET amplification. So that's why it's very important to do the genomic profiling. I know that it's also a controversial topic. A lot of people will say, oh, we are not ready. You know, why you're doing that? Put them on chemo and forget about this. But this is something that is evolving as we speak. And I think when we are doing research, it's very important that we repeat the molecular profiling for all of these genetic fusions in lung cancer. For NTRK therapies, we already have found resistant mutations that have been well described, not only in lung cancer, but also there are resistant mutations arising in patients with other cancers, because as you know, we have treated a lot of fibrosarcomas and other types of tumors that carry these NTRK fusions. That's the reason why we have been developing an agent called LOXO-195, and other companies like Tesaro and other companies have other potential agents that can help us to treat these patients to overcome resistance. There are already preliminary presentations from LOXO-195 that shows that the drug is able to rescue patients with resistant mutations. So that is why I think I'm very optimistic about the future. At least we have now like a second generation NTRK inhibitor that will be able to rescue patients that fail our first line of defense for these patients. The role of next generation sequencing is very important because, as I mentioned before, that's what we do now. I guess everybody agrees that we have to do at least one next generation sequencing, DNA testing in every patient with lung cancer. There is a little bit of controversy about doing again the NGS at progression, as we just discussed. And also, it's important to understand that probably because of this NTRK, especially 3 patients have different variants that maybe cannot be captured by the DNA sequencing or sequencing of the DNA. It's necessary that we add the sequencing of the transcriptome, the RNA sequencing, to complement and be able to discover the genetic aberrations that we cannot discover when we only analyze DNA. Also, we know that we can use in specific cases immunohistochemistry, the pan-TRK antibody. The pan-TRK antibody seems to be good. As I said, we have a very specific, we know more or less what genetic aberration I'm going to find. If I know, for example, this is a patient with a high incidence of N3 genetic aberration, like the secretory breast carcinomas, maybe I can pinpoint and look for that genetic aberration. I don't have to be worrying about other NTRK fusions or genetic aberrations. So that's why there is a little bit of room to be a little bit more flexible and maybe incorporate the pan-TRK immunohistochemistry. I'm talking about to do cost effectivity, because I understand you cannot be doing next generation sequencing so often because it's a very expensive test. However, the cost is going to go down, hopefully, like everything else in science, in medicine. So we will be able to do it more often. But until that, we have to find other ways to work. And certainly, we will love to see accurate pan-TRK immunohistochemistry, so all of us can do it in any part of America, in any small hospital, in a most cost-effective way.